Make sure I clicked all the right buttons. Great. So, chapter 31, orthopedic injuries. We're going to talk about our musculoskeletal system here for just a brief little bit. We have part of our musculoskeletal system being the cartilage, ligaments, and tendons that form our joints, hold our muscles to those bones, and make everything connected and make us able to move. There are a ton of ways that these things can be injured as far as orthopedic injuries go. Cartilage allow for flexibility. It's what keeps those bone ends from rubbing together. You know, you start to think about our elderly folks, and when you talk about osteoarthritis and bone rubbing against bone, it's because a lot of that cartilage has broken down and sort of gone away, and we'll wind up with limited range of motion when we see problems with cartilage in things like the knees and the shoulders and the hips and all over there. Ligaments connect bone to bone. So ligaments go across a joint to provide stability to that joint. Tendons connect muscle to bone, and they're what allows for our articulation. They're what makes it so that I can flex and extend all the different joints in my body and allow me to be able to move and pick things up and put things down and whatever else I want to do. The thing to think about when we talk about ligaments and tendons is they don't have a really, really rich blood supply. So they're not really good at healing. That's why when you hear about like a football player who blows out an MCL or tears an Achilles tendon or something like that, they're on the shelf for a really long time, because after the surgical repair, these things have to go then and repair themselves and grow back together and really form as strong of a structure as it had before. And since they don't have a rich blood supply, it takes a really long time. Just keep in mind and try and file this away somewhere that ligaments connect bone to bone and tendons connect muscle to bone. Moving right along through our bit of review of anatomy, we'll talk about bones. Bones are dense connective tissue. They are vascular, they are susceptible to bleeding on injury, and they are covered by a periosteum. Peri meaning outside, osteum meaning bone. So what do we know about those things like our pericardial sac and our periosteum when we're talking about vascular injury and bleeding? You guys have pericardial tamponade nailed down pretty quick. What happens when blood fills that pericardial sac?
Puts pressure on the heart.
All right, so what do you think happens when we have blood filling up that periosteum?
Same thing, it's gonna put pressure on it.
Yeah, it's going to create a pressure. When we were talking last week about things like crush injury and compartment syndrome, that periosteum doesn't have much stretch, doesn't have much flex. So any additional buildup and pressure in there is going to put pressure on the bones, the soft tissues, the nerves, the vascular supply, so all of our arteries and veins that are in the area. And that's why we see things like compromise to circulation, sensation, and motor function sometimes. And that's why we check our CSMs before and after we put a splint on. So we have realistically 8 of these that we need to know cold. We have those 7 upper extremity injuries that we worked on yesterday. We have our femur, which is the largest, strongest bone in the whole body, surrounded by the largest muscle groups in the whole body. We have a splint for that, meant for an isolated, closed midshaft femur fracture. As far as the rest of this stuff goes, I don't see a whole bunch of difficulty in identifying like what's a rib, tibia, fibula, those kinds of things. The medical term for our kneecap is the patella. We have the ilium, which is the sort of crest of our pelvis. We have the hip joint, the knee joint, the elbow joint, the shoulder joint. These are all things that are pretty common as far as terminology goes. Know that tarsals and metatarsals are the bones of the foot. Carpals and metacarpals are the bones of the hands. And phalanges, those are our fingers and toes. That's probably about as really deep and significant as we need to get into this kind of stuff. Bones are classified in one of these four ways. We have irregularly shaped bones, long bones, short bones, and flat bones. So we'll get into our picture. Irregularly shaped bone, things that are like your vertebrae are considered irregularly shaped bone. Our scapula, that's going to be a flat bone because, well, your shoulder blade is flat. Moving on down through our picture, we have flat bones on the ribs. We have long bones of the humerus, so humerus, tibia, fibula, femur. Those are going to be our long bones. Why? Because they're long. And last but not least, we have the short bones of the tarsals in our foot. They're just really lumped together in shapes. So, bones will heal themselves. If a bone is fractured, it will eventually start to grow and mesh itself back together. We have the ability to self-heal and regenerate and grow that fracture site back together. Unless, of course, we have interruption of blood flow. If the blood flow is compromised in that area, those cells will be like any other cells and they'll begin to lyse and die because of that hypoperfusion. That's why we have that one attempt, if we don't have circulation distal on the extremity, to line those bones back up, because we need to restore that blood supply as early in the game as we can. We have three different kinds of muscle. Our skeletal muscle, that's our voluntary muscle. Those are the ones that are under our control. It's what tells me to get up and get out of bed in the morning, and that's what allows me to do it. I force myself out of the rack, onto my feet, and start my day with a cup of coffee. My voluntary muscles are what's going to be dragging me through that scenario. Smooth muscle, all the involuntary stuff, think of the muscles that line your digestive tract and move food along through your digestive tract, or the muscles around your arteries that allow them to expand and contract, say when we give things like nitroglycerin or epinephrine. And then our cardiac muscle, our myocardial muscle, is a form of involuntary muscle. We don't have to think about our heart beating all the time. But myocardial muscle is special. Why?
It's its own muscle that it has its own electrical system.
Bingo! It's got its own electrical charge. It can generate its own impulse to do whatever it wants. Every single cell in that entire myocardium has the ability to do that. Good. So here's what our ligaments and tendons look like. They are sort of like elastic, rubbery kind of thing. And you'll see your ligaments on the left-hand side of the picture going across from one long bone to another and connecting that joint so it makes everything sort of hold together. When we see significant injury to ligaments, it really calls into question the actual stability of the joint and its ability to hold itself together. Because if we have enough ligament damage, that joint is got really no foundation. There's really nothing piecing that all together. When we see tendon injuries, if we have an injury to the tendon, what does that a lot of times preclude our patient from being able to do? What can't they do anymore when we have injury to a tendon?
Usually, I mean, you're going to lose, say, in the knee area, you're most likely going to lose stability, be able to stand up or pivot off of it and move in a certain direction.
Yeah, you're going to lose the ability to use that joint appropriately, because with the tendon connecting that muscle to the bone, The tendon is what actually allows that joint to move. When we flex that muscle, it pulls tight, it makes the joint do something. When we relax that muscle, it lets the joint go slack, and it allows us to do something. When we see injury to a tendon, it's going to make the joint more difficult for the patient to move. Now, other muscles and other forces at play may make it so that the patient, yes, can still move that joint some, but the tendon injury is going to be what makes it difficult and painful. So we're going to talk a little bit about the mechanism of how these injuries occur. We have direct force injuries, we have indirect force, and we have twisting. So we're getting into either A, something smashed into it, B, something else in the body smashed into something, and now that force is actually transferred up through the body, or we have a rotational force applied where the bone is just unable to maintain itself in a connected fashion. Any break in a bone's continuity, whether it's open or closed, is going to be a fracture. Now, for us, the word fracture should come hand in hand and be pretty synonymous with painful, swollen, and deformed extremity, because we don't have X-ray vision. So we always think any painful, swollen, or deformed extremity has a possible fracture. But since we can't really get the wheres and what fors of is it actually broken, we just call it a painful, swollen, or deformed extremity. Comminuted fractures are bones that are broken in several places. So when you hear somebody had, a skiing accident and their leg was broken in 3 places, that's what we would call a comminuted fracture. A green stick fracture is just that. It's normally from a bending force being applied to a bone. A lot of times this is how kids' bones will actually break. And if you've ever pulled like a branch off of a tree and went to break it, you know how it sort of starts to splinter and kind of forms these gangly looking finger things as you're bending the stick and it starts to give way? That's what this bone will actually look like on X-ray. You'll see the little splintered fragments of the fibers just starting to break because the bone will bend and bend and bend just like a green stick. But it soon enough gets to a point where no more stress can be applied before it starts to come apart. And then angulated fractures. Anybody who watched that MMA fight on, what was it, Saturday night, saw a pretty good indication of an angulated fracture. When things are bent somewhere where there is no joint, you're going to have an angulated fracture at some point. This is probably my least favorite of all. Like, all right, comminuted, at least if it still looks the way a leg is supposed to look, that's all well and good. Green stick, it's going to be painful, it's going to be swollen, maybe some deformity. But these angulated fractures with things pointing in wrong directions and feet twisted the wrong way, and not really my jam. So those are our fracture type injuries. Now we're going to talk about injury to some of the connective tissue. When we have injury to the connective tissue, the ligaments, the tendons, or the cartilage itself, we'll have dislocations, sprains, and strains. Dislocation actually means coming apart of a joint. So a shoulder dislocation means the joint is no longer intact. So all the distal portions of that patient's arm are no longer really connected to the patient's trunk, the patient's body. A sprain is stretching or tearing of the ligaments. That's why I'm sure you guys have all heard if you sprain an ankle, you would have been better off breaking it, because broken bones have such a rich blood supply and they almost immediately start to rebuild some of that scaffolding and start to grow back together. Sprains, being an injury to the ligament, which doesn't have quite as good of a blood supply, take ages to heal. And then last but not least, we get down to a strain. Strains are for muscles, sprains are for ligaments. So overstretching, overexertion of a muscle is going to lead to a strain. So if we can't actually diagnose fractures in the field, Why do we do all this splinting?
As a precautionary measure.
Okay, I'll take that as a precautionary measure for what?
Maybe to eliminate like further injury.
I like it. Absolutely. We're splinting that extremity to prevent further injury. Preventing further injury is going to help prevent any additional unnecessary blood loss from the bones, the tissues, any possible vascular compromise, any possible neuro compromise. If we show up and the patient can still wiggle their fingers, feel us touching them, still has a distal pulse, and we splint that extremity, the minute we get that splint on and get it properly applied, that suspected fracture, that painful, swollen, deformed extremity, no longer has the ability to cause any more damage. I mean, the damage is all already done. You can't, you can't unbreak the bone. But we can prevent those sharp bone ends and prevent all those splintered pieces of bone from going and now severing a nerve line, poking a hole in an artery, poking a hole in a vein, creating any more tissue damage. Because the more of those things that are allowed to happen, the more bleeding, the more bleeding, the more swelling, the more swelling, the more pain, the more bleeding, swelling, and pain, the more uncomfortable it is for our patient, and the longer and more difficult the actual heal time is for this patient. So we'll talk about all this stuff and get into splinting of our extremities and orthopedic injuries and all that good stuff. But we would be remiss if we didn't start right where we know that we're supposed to. Rapidly identify and treat any life-threatening conditions that have anything to do with massive hemorrhage, airway, breathing, or circulation. Because it doesn't really do us a stitch of good to show up with a perfectly packaged dead patient. So yes, there may be some grotesque wounds, there may be some really mangled up looking arms, legs, and whatever, but we have to get in the habit of thinking about, if that injury looks so terrible, is it likely that this patient has sustained other injuries? Is it likely that this patient maybe has sustained injuries that are so detrimental or so at least questionable that we can start to see some problems with their ability to still be a live person? Complete your primary assessment to a T every single time. When it comes down to how are we going to treat the actual injuries itself, if it is just a simple fracture or a simple painful, swollen, and deformed extremity, you guys already nailed that down pretty good yesterday. We're going to cut or remove patients' clothing because we want to be able to see everything. We're not going to have them take their shirt off because, remember, we're trying to limit movement. So we cut the clothing in the area we want to take a look at and be able to identify problems with skin color, temperature, and condition distal to the injury. We want to make sure we verify those CSMs and check again after we've done all of our work. Why do you think that is?
To make sure they're still getting circulation from beginning to end.
Right. Do you think it means you did anything wrong if all of a sudden circulation, sensation, and motor function are compromised and you're finished?
I mean, possibly. If you splint it wrong, incorrectly, maybe too much pressure is not a good thing. It's going to be an equal force of pressure to hold that in position to prevent any more damage and keep blood flow accurate.
Okay, I'll take that because you hit on both of the things I wanted to talk about. So is it possible? Sure. But you guys just went through a splinting rotation yesterday, and we're going to work on that some more as time trudges along here. What you probably learned is it's not a very hugely difficult skill, right? I mean, there's a lot of bits and pieces, but at the root of it, it's not, impossible. But what is going on the entire time we're splinting that injury? we have increased swelling, we have increased leaking from the tissues, because remember, the damage is already done. So all of that increase in swelling, all of that increase in damage, all of that increase in problem in that area is just going to continue to increase while we're putting the splint on. So it is entirely possible that you could do everything by the numbers, hit every mark, and make sure that you did everything appropriately. And when you get to the end, and then your patient's complaining of some paresthesia, some tingling in their hand, and maybe it's difficult to find that pulse, and maybe they're having a difficult time making a fist and holding that position of function. Doesn't mean you did anything wrong. It means you need to go back and fix it, but it doesn't mean you did anything wrong. It just means that the swelling now has gotten so severe that a patient's body may no longer be able to perfuse those tissues. There may be so much swelling in that extremity from the fracture that we're starting to deal with crush and compartment syndrome just based on the amount of bleeding and swelling that's in the tissue, now causing that increase in pressure. And if the pressure gets too big, blood flow will be obstructed, and those tissues will wind up hypoperfused just based on the anatomic problem that's going on. It follows the same exact progression that once blood flow is interrupted, cellular damage starts, causing more swelling. More swelling causes less perfusion. That less perfusion is eventually going to completely seal off blood flow from the area, and that pressure is just going to continue to build and build and build, and more cells are going to get damaged, and more tissue is going to get damaged, until eventually, if perfusion is not restored, they actually can wind up needing to have that limb removed because of all the secondary tissue damage and swelling and vascular compromise and nervous compromise and ischemia or infarction that happens to that area just based on the amount of swelling there was in those tissues. That's part of the reason most of the time when you go to the emergency room now with a broken bone, they don't put one of those full hard casts on anymore, because they want to give it some time for the injury to actually stop swelling and some of that swelling to reduce. Because when they take and stuff a fracture like that, that is still going to continue to swell for a period of time, into a cast, into a hard cast, that tissue's got nowhere to swell to. That perfusion is going to be compromised, especially in the lower portions of our lower extremity and the distal portions of our upper extremities. That fascia that surrounds the bone, that periosteum and the fascia around the muscle, it gets really, really constrictive really, really fast. And you'll wind up with some compromise to circulation, sensation, and motor function. And again, it's not because anything inappropriate was done. It's just you never know how much swelling there's going to be. And by the time you finish, maybe there was too much. So how do we do our assessment of all these things? Especially if we're talking just isolated orthopedic type injuries, we're going to look for pain and tenderness, deformity and angulation. To me, those are the exact same thing. If there's a bend in a patient's forearm, somewhere where there is not an elbow or a wrist, that's a deformity. Crepitus is that grating noise that you'll hear when you palpate and those bone ends are kind of grinding together. Swelling and bruising, so there we have part of our DCAP BTLS. I will say you don't need to be an ER physician where if you see bone ends poking out through the patient's skin, that tells me pretty well that there is some injury to the patient's bone. What do we do with those?
We are going to most likely wrap bandages around as best we can. We don't want to push it back in because it's been exposed to bacteria, and we don't want to try inflicting any more damage or pain.
Perfect. if we have joints that are locked into position, now I'm not saying taking your patient's, fractured arm and trying to move it all around. But if your patient has the inability to move their shoulder or inability to straighten their arm because they have an elbow problem, or the same goes for the lower extremity if we're talking knee, hip, or ankle, joints that are stuck in position are obviously a significant finding. We have nerve and blood vessel compromise when we have compromise to our circulation, sensation, and motor function. And if we see a rapid increase in swelling to the area, one of the things that might lead us towards compartment syndrome, let's go back and have a look at this guy's foot. What do you notice about this right away?
Swelling.
Yeah, a ridiculous amount of swelling, and it looks like you could just pop that guy's foot like a balloon, doesn't it? The skin gets stretched really, really far and really, really aggressively by that increased amount of swelling. So if we're starting to see some possible compartment syndrome develop, not only are we going to have pain and tenderness and some increase in swelling, we'll see changes to skin color, temperature, condition, that paresthesia that I talked about, compromising the nervous flow. We'll have diminished or absent pulses, maybe complete paralysis of that affected injury site altogether, and the quality of their pain. It's going to feel like a crazy amount of pressure inside the tissue. It's because it is. So any of these 6 P's are going to be compromised to circulation, sensation, or motor function. These are all things that we're going to be able to see, or our patient's going to actually be able to tell us. Something to always think about when you're dealing with musculoskeletal injury is, do all of these injuries wind up with a critically ill patient? Is this a serious multiple trauma event? Off the top of your head, come up with a couple that could possibly add up to a patient who's really, really sick. Give me 1 or 2 injuries that you think, either alone or lumped together.
A broken femur that's punctured through the thigh. Hitting an artery.
So open fracture that's gone through the femoral artery and lots of bleeding. I like it.
And multiple broken ribs or a broken sternum.
Yeah, how come?
Because it could puncture the lungs.
Could puncture the lungs. What else could they have a very significant impact on?
On the heart.
How about just the patient's ability to move gas from the outside to the inside?
Yeah.
Our flail chest. It's really kind of an isolated injury. But if you think about the things that it has the ability to impact, it is a significant musculoskeletal find, just based on the fact that it is going to interfere with the mechanics of breathing. So, as with anything else, we got our scene safety BSI, beginning our patient care modality. We perform our primary assessment. We start forming our general impression. We get our patient's level of consciousness with AVPU. Then we move on to our alert and oriented questions. Who are you? Where are you? What happened? What day is it? We move into our secondary assessment. We're going to decide to put a cervical collar on the patient or not. We're going to handle this right now as just isolated injury. So we're just going to talk straight orthopedic. Patient got their arm slammed in a car door, something like that. Think simple for this lecture. If we suspect there's a spinal injury during our primary assessment, obviously we're going to have our partner hold C-spine. We'll get a collar on after we check the patient's neck. But let's talk straight orthopedic for a minute, because we already did spinal. We want to splint any suspected extremity fractures, absolutely, but only after we've treated our life-threatening conditions. That's during our, transport. If we found no problem with A, B, or C, we're not going to be on scene splinting wrists and forearms, because that A, B, or C problem is what's going to take your patient out of the game pretty quick. The broken forearm is clearly a formality for me to splint when we're on our way to the emergency room. Alex, you were spot on when you said cover any open wounds with a sterile dressing, including any exposed bone ends. We do not want to pull those back inside the body because we introduce all sorts of nasty bacteria from that point on. That's why our traction splint is for a closed mid-shaft femur fracture. Because if it was an open fracture and those bone ends had been exposed, and now we pull them back in, we are introducing much more problem to this patient, and their day is already bad enough. What's our advantage to this splinting? Why do we do it? Well, we hit on the big stuff. It prevents any further injury. It prevents any additional compromise to those nerves, arteries, veins, and muscles. But let's talk about what it does for our patient actually physically. It actually can help to minimize the amount of pain by not allowing those bone ends to grate on each other anymore. It can minimize the amount of pain by limiting the ability for those bone ends to go playing, playing around with all that soft tissue and causing additional blood loss. It helps to decrease the pain. You guys were all in splints yesterday, and I'm sure you've figured out by now that if you wanted to make that extremity move, you could. It's one of those things that's just sort of like a reminder to our patient, because with all that's going on with this patient, their body's going to have released some epinephrine. They're going to have that fight or flight response started off. So it would be something that your patient would actually still be trying to move, still be trying to get comfortable. But our splint, as much as, yes, they could overpower it and move if they wanted to, it's a reminder to them, like, hey, don't do that, that's broken. We realign our deformed extremities to fit to the splint because we're trying to restore perfusion. If we don't realign the extremities like we're supposed to, the splinting will be ineffective. It will cause an increased amount of pain and possible further injury. So we want to splint things in anatomical position. We don't splint things bent every which way but straight. That being said, if the injury won't realign easily, we splint it in the position found. Because it's very likely if you try and force it back into anatomic position, you're going to cause an immediate increase in the amount of pain, and you could compromise that circulation, sensation, and motor function that we are trying to maintain. The same goes for our injury that is pulseless, distal to the injury site. You have one opportunity to pull along the long axis of the patient's bone, so pulling it towards you in the direction that the bone goes to try and restore a pulse. If you restore a pulse, great, splint it and be on your way. If you don't, or you meet any real type of resistance, stop and splint it how you found it. Because playing tug of broken arm with the patient isn't going to win us any friends. It isn't going to do us any good. When we are splinting and trying to realign things, it is gentle traction. It's not, yanking. You're pulling smooth and easy with a considerable amount of force because it's going to take that kind of force. Your partner is going to hold the patient's arm, if we're looking at this picture here, and you're going to pull. Here we're probably dealing with, I would say, a forearm, and we're going to realign that extremity, and then we will go into my partner's going to hold stabilization. I'm going to make sure that, yes, those CSMs are actually there and restored. I'm going to splint, I'm going to sling, I'm going to swath, I'm going to go back and recheck my CSMs, and we're going to get out of here because this patient needs to be transported to the hospital, the closest appropriate facility with an ALS intercept en route. When we realign these bones, it is likely to cause an increase in pain, but only momentarily. Still going to hurt, but our increase of that pain is not likely to be long-lived. Don't expect a Christmas card. So now we're going to actually get into it. And since you guys did the meat and potatoes of this yesterday, we should be able to cruise. But any long bone injury, so forearm, humerus, any of our long bone injuries, the idea behind splinting is to splint the joint above and below any long bone injury. So when we're splinting a forearm, you notice that the wrist was in place and the elbow was in place with the sling and swath, so that my patient's arm was nicely packaged together. And yes, they could still wiggle their fingers. I still had access to check their pulse. But why do I want to splint the joints that are above and below wherever that injury is?
So you can get proper stabilization.
Yeah, but how does that give me proper stabilization? If they can move the joints that are connected to that bone, what are they still doing?
You're still moving the injury.
Yeah, they're still moving the injury. If I don't splint that wrist and splint that elbow and get everything properly immobilized, like Mike said, Pat's absolutely correct. If they can move their wrist, the wrist is connected to those bones in the forearm, and those bone ends are still grinding away, making soup out of my patient's soft tissues and really causing more trouble. So our long bone splints are meant to immobilize the injury itself and the joints that are connected. Our elbow splints and our shoulder splints, therefore, are also going to immobilize the long bones above and below. Because if I have a fracture at my elbow and my patient can still move their hand all around, they're still moving that elbow, they're still moving that fracture, they're still causing just as much tissue damage. So long bone splints, we want to make sure we encompass the joints above and below. Joint splints, we want to make sure we encompass the long bones above and below. That's why we put on the sling and the swath and keep everything as a nice tight package to the body, so that you can't continue to move the other parts and pieces and just continue to damage and damage and damage. If we're going to put the splint on, we want to make sure that we are stopping the damage right from the moment we get there. So get ready, because here comes a picture.
Oh,
I warned you. So, candidate for a traction splint?
Definitely not.
Yeah, definitely not. First of all, it's open. And then let's look at where it is. Even if that was closed, that's not really midshaft, right? That's really close to the knee.
Actually looks like the, yeah, it's torn right off the knee.
It looks like it, right?
Mm-hmm.
So we identified that correctly. Now let's take a peek at this one. Do we think that this is a candidate for a traction splint?
Yes.
Yeah, that's like right dead center in the middle of the thigh, and that is going to do all of the things that we want it to. When we have a fractured femur, isolated closed midshaft femur fracture, you're likely to see a leg that is shorter than the non-injured leg. You're likely to see some external rotation of the patient's foot, and you're likely to have some spasming of the muscle, which is just making the pain worse. Those muscles are going to continue to contract and pull those bone ends back and forth. It's like running it through a cheese grater at that point. And we're just going to increase the amount of damage that's going on. Our traction splint is meant to counteract that. Our traction splint comes in a couple of different flavors. You'll see the bipolar traction splint here in class, and that's pretty much what you see in the state of Massachusetts. But what this does is it counteracts that muscle spasm. When we pull traction on that broken femur, we make the legs the same length again. We line those bone ends back up, and we stop all of that muscle contraction from increasing the patient's pain. Our traction splint is just what it sounds like. It is a mechanical force that's applied to that fractured femur that lengthens everything back out. So we are going to pull traction on our patient's fractured femur until mechanical traction is taken over, until the patient feels relief. Now, don't lull yourself into thinking that the patient is, right as rain and going to be moving on and having a nice, happy day, but they're going to not be screaming anymore. And until the legs are the same length. We don't want to just continue to make that leg longer. We want to just line the bone ends back up so that they're no longer grading past each other. We're going to go over all this in class, but here's a decent picture. So we have 4 stabilizing straps, we have a proximal securing device, and we have a distal securing device. We put the splint underneath. We apply that proximal securing device right up in the patient's groin, as high up as we can get it. We put a kickstand up so that it'll hold the leg up a little. We put our distal or further away securing device, the ankle strap, on our patient's foot. We attach the splint now to that distal securing strap, and we turn a crank. And that mechanical force is going to take over and fix all that ails this patient. We're going to go over this today in class, and you'll see that this piece of equipment makes a lot of sense. If you look at it and see, once you understand what it's doing, that there's really only one way you can put it on, and it makes it a whole lot easier when you see it in person. So if we look at, and since we've talked mostly about upper extremity splinting and upper extremity type injuries, if we look at the way that the lower extremity is structured compared to the upper extremity, you see that they're both very, very similar, right? We would splint the knee the exact same way we would splint the elbow. We would splint the ankle pretty much the exact same way we would splint the wrist, and the same with the tib fib. So our lower extremity splinting isn't something that we go over. It's not really something that you're tested on. But if you look at the anatomy of those 2 spots on the body, the same rules apply. Splint the extremity appropriately when you have splinted the associated joint and the long bones above and below, or the associated long bone and the joints above and below. It depends on which part that we're splinting, but this picture here of them splinting a patient's knee is pretty good at driving this point home. If you just look at the anatomy the way it presents you, it's all the same. It's just a little bit structured a little bit differently. The splints are going to apply in the exact same fashion, and it really doesn't cause us altogether that much trouble. Now, we talked a little bit about injuries to the ankle and foot, and Kevin and I mentioned the ability to form and fashion splints from all sorts of things, and this is going to be one of them. A patient who's got an ankle injury or a foot injury, we can take and use a pillow and some tape. Your ability to appropriately splint something is really limited only by your imagination. Remember, this is objective driven. Did I splint the long bone below the joint and then the long bone above? Did I splint the joint, the long bone, and the next joint? Then I've met the objective and I have taken care of this patient appropriately. If something looks nuts but it worked, it's also not nuts at that point. Pillows are great at this kind of thing. Why do you think it's important though with the way this foot is positioned? Take a look at some of the stuff that's poking out through that pillow.
So you have the toes pointed out so that you can check pulse and CSMs. It's also elevated, which means you're not going to get any, it's going to help reduce swelling.
Perfect. We're going to have a decrease in swelling from keeping it elevated. I can continue to monitor and watch those toes to make sure that they're not turning purple or swelling, or I'm not having anything else that leads me to believe that we are generating a problem with what we've done. And it's very, very simple. I turn my head, I look, toes still look pink, warm and dry. I touch them. Hey, can you tell me what toe I'm touching? Yep, the big one. We're good to go. That's why I say splinting is one of those things that, since it's objective driven, it's a lot of it's open to interpretation. Yes, you are going to hopefully apply all the splints, the same. Everybody's going to do everything the exact same way. That makes my life better. But when you get out to the field, truth be told, there's nothing stopping you from doing things differently as long as they're still done appropriately and you keep in mind what you are actually doing. I'm trying to limit movement. I'm trying to limit swelling. I'm trying to limit further damage. If it's a joint, I need to splint the long bones above and below. If it's a long bone, I need to splint the joints above and below. And as long as you have that part of it appropriately packaged up and you verify CSMs continuously after you've applied the splint, you're in good shape. And that was orthopedic injuries 101. You can look at all the gross pictures in your book that you want to. All right, so that was chapter 31. Does anybody have any questions? All right, so before we get started here on birthing them babies, we're going to take a break. And when we come, this is a long lecture. I'm probably going to bring up some additional stuff on caring for the neonate after it's born. So we're going to take a couple of breaks throughout this one, and we're going to take our first one right now. So it's coffee o'clock. Why don't we take 15? And when we come back, it'll be around 9:40, and we will get stomping away through our obstetrical lecture.
Awesome.
All right, everybody, we're back. So, any questions as far as orthopedic injuries go? All right. So then, moving right along, we are going to get into obstetrics. Now, this is a particular area where you guys are going to want to make sure that if you have any questions, we get them answered, because OBGYN is one of those places that people get hung up on when it comes time for the written. So OBGYN and care for the neonate is going to be a decent place to spend your time when we start getting ready for taking the exam. We'll get into anatomy and physiology. This is what we covered yesterday, but just a little bit more of it. We have the ovaries, where the egg is released from. They travel down through the fallopian tubes into the uterus, and that is where a fertilized ovum will implant. The uterus is a hollow muscular organ. The inferior-most portion of the uterus is going to be the cervix. The cervix is a muscular organ that most of the time is closed. It is what keeps the internal portions of a woman's reproductive organs as internal organs. The cervix is a muscle, it stays closed, and it allows for the sperm that's implanted in the vagina to travel through and get up into the uterus to actually fertilize that egg or not. Excuse me. When we talk fertilization, does anybody remember how often this cycle repeats itself?
Once every 28 days.
Once every 28 days. If the ovum does not get fertilized, then that egg is still just an egg. The lining of that uterus will slough off and detach and will be passed through. And all of this is really based on hormones, estrogen and progesterone. Estrogen being the one that this is mostly dependent on, is going to be your two main hormones of female reproduction. There's 2 ovaries, 2 fallopian tubes, 1 uterus, 1 cervix, and, well, really just one of everything else. When a baby begins to grow in utero, the placenta is what attaches baby to mom, and that is how all of the nutrients, all of the oxygen, all of the everything gets into this baby and allows it to continue to grow and develop. The placenta attaches to the uterine wall. They both have a very rich blood supply, very vascular. The placenta is what keeps that baby going. It is what gives it its oxygen, is what provides it its nourishment. It's also what allows it to get rid of carbon dioxide and waste products. Babies do not go to the bathroom generally inside of mom's uterus and inside of the amniotic sac. The umbilical cord is what connects baby to placenta. Without the umbilical cord acting as that baby's lifeline, then baby is still not attached and still not getting any of those nutrients, any of the oxygenated blood, any of the anything that it needs. In our umbilical cord, there is 1 vein and 2 arteries. And then we have the amniotic sac filled with amniotic fluid that the fetus floats in. The job of that amniotic sac and the amniotic fluid is insulation and protection throughout the entire pregnancy. It's meant to absorb shock. It is meant to keep the baby heated to 98.6 degrees. And there's somewhere between 1/2 to 1 liter of fluid inside that sac. We talked about the average of 28 days. That is, in fact, the actual average of a menstrual cycle. It can be anywhere from 24 to 35. It is controlled, like I said, by estrogen and progesterone. Ovulation generally occurs on the 14th day of mom's cycle. So that means that egg is released by the ovary, it travels through the fallopian tubes, and either gets fertilized or does not. If it's fertilized, it implants in the wall of the uterus, and once that happens, we enter the embryonic stage and that baby starts to grow and develop. If no implantation, no fertilization has occurred, the cycle just starts all over. We have normal menstrual period, and within the next 28 days, it all just keeps right on going. So the pre-embryonic stage, that is the first 14 days after conception to where the baby maybe hasn't even fully implanted itself yet. The pre-embryonic stage is just when those cells begin to divide and things begin to start happening. From day 15 through 8 weeks, that baby is now an embryo. It is implanted in the wall of the uterus. It has begun to sort of grow and develop and starting to form. And when we get through those 8 weeks, we enter what's called the fetal stage. The fetal stage is from 8 weeks until delivery. We call this baby a neonate. Care for the neonate is going to be something we talk about sort of at the tail end of our talk here. What do you think we're referring to when we refer to gestational age?
The age inside of the mother's stomach?
You got it. From the time of fertilization to delivery. It's termed in weeks. A patient who is 36 weeks of gestation is in their 36th week of being pregnant, of actual fertilization and growth of this baby. Full term is considered 40 weeks. It's about 280 days. That's why they call it 9 months, because 9 months and 10 days doesn't really have the same ring to it. Each of those 9 months is broken down into 3 3-month trimesters. And when we talk in terms of trimesters, they're broken down pretty evenly. But what we think about is stage of fetal development through those trimesters. We have months 1 through 3 of the first trimester, 4 through 6 of the second, 7 through 9 of the third. Most of our fetal emergencies are going to occur in either the first trimester or the third trimester. They say that the second, for whatever reason, is the most stable point in the pregnancy. When we look at mom, our patient, because until the baby's born, we don't really have two. But when we look at mom in general, we think about some of the changes that her body is going to go through in order to grow this human, because that is what she is doing. There are changes in the reproductive system. The uterus is going to get bigger and become more vascular. It actually will take up somewhere around 20% of mom's circulating blood volume to perfuse that organ and that baby. The cervix, in order to maintain itself as completely sealed off, forms a mucus plug that actually will make it completely and totally impenetrable. It protects the fetus from infection. You'll see mom's breasts actually starting to enlarge and prepare to supply food to this little growing human. What do you think some changes are that go on with mom's respiratory and cardiovascular system?
Everything gets elevated, higher blood pressure, increased swelling.
Hard to breathe.
So it can be hard to breathe. Her oxygen demand actually goes up by a lot. Goes up to by about 20%. The resistance in her airways actually goes down. So we see some relaxation of that smooth muscle around her bronchioles, which means that it is much easier for her to get gas in and out. When we talk about harder to breathe, it's just generally as that baby becomes, gigantic and the turkey's about done, that things become a little bit more difficult. Mom's tidal volume, so the amount of gas she takes in with every single breath, is going to go up by around 40%. And that's just the respiratory system. Cardiac output increases in mom, her blood volume increases, her heart rate increases. All of this is in an effort to continuously supply the growing person inside of her what they actually need. And then the GI system has a different problem. Things in the GI system actually begin to slow down because that blood is needed elsewhere. So it's very common to have nausea and vomiting in the first trimester. It's very common to have bloating and constipation throughout the entire pregnancy. The peristalsis and the supply of blood to that gastrointestinal system is going to begin to go down a little. There'll be increased blood flow through the kidneys, so we're moving on to the urinary system. The urinary bladder actually gets displaced by the baby's head. There's not really the greatest picture of it here, but if you look, and if any of you who have kids out there can remember back to their wives being pregnant and feeling like they always had to pee, take a look at why they always had to pee.
Sitting right on that bladder.
Sitting right on that bladder, pushing on it. And then think about when we talked trauma to the genitourinary system yesterday, and we talked about how the bladder becomes more susceptible to trauma. When the baby's head is displacing that bladder and pushing it more towards the anterior and squishing it, it's also pushing it right towards the symphysis pubis. So mom's pubic bone is right up against that bladder. And we start to think that it becomes a problem with a trauma patient because that bladder is now under pressure from both sides during a trauma. Mom's body releases some hormones that actually change up the musculoskeletal system as well. Our pelvic joints actually begin to loosen, and it allows for greater flexibility and more stretch as the body actually prepares for that baby to now start exiting from the uterus, through the cervix, through the birth canal, and out into the world. Anybody can think back to the change in the way you see a pregnant person walking. Their center of gravity changes with that big belly and the baby growing in the uterus. And you add to that now, those pelvic joints are a little less stable, a little less intact, and they have that very particular way that they walk.
Like a penguin.
Like a penguin. I was waiting for somebody to say something.
I called it the wobble.
Yeah, you're absolutely right. They wobble, or it's a little bit of a kind of a waddle shuffle looking thing. And it's really just all preparation for the body to do what the body does. And that is expel that human out into the world. So now let's talk some pre-delivery emergencies. Antepartum means pre-delivery. And let's get into some of the problems we can see before the baby's actually born. One that we have here, spontaneous abortion. This is a $10 medical word for a miscarriage. So spontaneous abortion is this baby is being expelled prior to being a viable pregnancy. So egg has been fertilized, implantation has happened, but before this baby is actually physically able to survive outside of the uterus on their own, for one reason or another, the pregnancy is no longer viable and the body is going to work to expel the embryo. We may or may not see vaginal bleeding during pregnancy. It's going to depend on, did the cervix open? Because if the cervix remains closed, but mom is having signs and symptoms of a spontaneous abortion, then we have to go on the fact that that is what's going on. Our pathophysiology of all this is really kind of a difficult thing, right? Because most of the time the doctors can't even tell why it actually happened. Normally it happens before the 12th week of gestation, so it's first trimester. They say anywhere from 20% or more of recognized pregnancies will end in a spontaneous abortion or miscarriage. Generally, it is some form of genetic cause, but it could be a problem with mom's uterus. It could be infection. It could be the body just needing to make a decision between the self versus not self. So if we see a mom whose body is under stress from some other cause, sooner or later, the brain and the body are going to make the decision that we need to save the host. We can make another baby. And that's not going to be of a lot of comfort to the family, but in an effort to save itself, the body's going to do what it thinks it needs to do. What we're on the lookout for is cramping or vaginal bleeding somewhere between when the ovum's fertilized and 12 weeks. Our patients may actually have already begun the process of expelling this pregnancy. They could be passing a lot of blood. There could be bright or dark red. We could actually, when we get there, see things like tissue coming out of our patient, and really our ability to fix any of this is non-existent. There's nothing that can be done for the pregnancy at this point. Our care is going to be for the people, the parents, the mom. Your ability to sort of rapidly develop an interpersonal relationship is going to be important here, because it's going to be supportive care. It's going to be a lot of nobody gets to go home happy type stuff. But at the end of the day, we provide the best care we can for mom, and what not to say. Well, that's okay. You can always make another one. Things like that. Like your mind goes weird places, and it's an uncomfortable situation to begin with. So just sort of let them guide the talk. Just be careful and choose your words very, very carefully and very thoughtfully if you're dealing with a patient who's in the process of having a miscarriage. Sometimes the patient will know that the pregnancy wasn't viable. Sometimes this could be an absolute surprise. So try and gauge where in the process they are, and really just go from there. I don't have any real words of wisdom as far as this topic goes. Our next bit of antepartum condition is placenta previa. Now, this isn't really the big, terrible, horrible, no good, very bad day that our spontaneous abortion was. Placenta previa is fairly prevalent. It's 1 out of every 250 births, and it can cause bleeding, especially during the 3rd trimester. What this means is the placenta has implanted and begun to grow, and when it did, it covered the cervical opening. So there could be a total, a partial, or marginal. Total means that the placenta, like in this picture right here, is completely and totally covering the baby's ability to get out. Partial means only part of the placenta has grown over the cervix, and marginal means it is just sort of at the very edges of the cervix. This is going to be one of those times where there will be bleeding as the cervix begins to thin and dilate because the placenta is prematurely disrupted from the uterine wall. There's likely to be some excessive bleeding because of the rich blood supply to the area. Some things that are likely to predispose mom to this condition. And a lot of what we're going to talk about as far as predisposing conditions for pre-delivery sort of complications, more than 2 deliveries, period, rapid succession of pregnancies. So moms had more than, my wife works with someone who in 13 months had two children. That would be rapid succession pregnancies.
Irish
In 13
twins.
months, her body did this twice. Age is going to be another one, an age of over 35 years. History is going to be another one. So previous placenta previa is a good indicator that it will happen again. And vaginal bleeding throughout pregnancy, and it doesn't have to be, an enormous amount of blood, but if they had some sort of vaginal bleeding, something was causing that. Bleeding either during or immediately after intercourse is something that is also sort of one of those telltale things. Really, it is painless bleeding during the 3rd trimester that should sort of start making us think this could be a placenta problem. Now, we're going to talk placenta previa. This is the placenta forming over the cervix. And we'll talk about placenta abruption here in just a minute. But if we're seeing a lot of blood, what do you think our care, what do you think our concern really is all about?
Survival of the baby.
Well, first, we have to be concerned with the survival of the mom.
Hemorrhage.
The best care we can provide for the mom is going to indirectly provide the best care for the baby. Who said hemorrhage?
Me.
So, what are some things that are going to point me towards some possible hemorrhage here? Because if the cervix is still going to be mostly closed, so we might not see a lot of blood. We might see some, but we're not likely to see a ton of it until the cervix really starts to open and dilate.
Could be the same as an internal bleed, so you're looking for a lower blood pressure.
So signs and symptoms of shock. This is a patient who could be in hypovolemic shock because of the vascular nature of this organ. So what do you think our appropriate medical care is going to be?
Transport.
Keep her warm.
Transport, keep her warm. What else? One more.
Oxygen.
Oxygen, bingo. We're treating for shock at this point. If your patient who is pregnant is complaining of mild to moderate vaginal bleeding, no pain, abdomen is soft and non-tender, but we see signs and symptoms of shock, that's not by accident, right? That is clinically significant. So we treat for what we've identified, and by adding extra oxygenation to mom, as long as that baby is still attached and that placenta is still doing what it's supposed to in some form or fashion, giving mom more oxygen is going to give baby more oxygen. Other than that, there's not much we can do for the baby's sake, other than to make sure we are appropriately taking care of mom and recognizing those signs and symptoms of shock and treating appropriately for those signs and symptoms of shock. Because the worse mom gets, the worse baby's going to do. Placenta abruption. Placenta abruption is when the placenta separates from the uterine wall, but not during normal delivery. So a placenta abruption means it has pretty much torn away from the uterus, either partially or fully. A full placenta abruption is a 100% fetal mortality rate. So a complete abruption means the placenta with the baby still in utero has completely removed itself from the uterine wall. So that means none of it is still attached, and the baby is not getting any oxygen, not removing any carbon dioxide, not getting any of the nutrients that it needs in order to maintain its position inside of mom. A partial abruption is a bit less extreme. It has a 30 to 60% mortality rate, so still not great, but at least there's a chance. Some predisposing factors to this, on top of some of the stuff we already talked about, are hypertension, any vasoactive drugs or medication. Preeclampsia is a big one. We're going to talk at length here in just a few minutes about preeclampsia. Really anything that affects mom's health negatively. So diabetes, smoking, drug use, you pick something and it's generally pretty much there. One of the ones that can't be overcome is a short umbilical cord. Why do you think a shorter than usual umbilical cord would make a placenta abruption more of a concern?
Any kind of movement will rip it away from the placenta.
Yeah, the baby will be in there playing tug of war with any movement if the umbilical cord's not as long as it's supposed to be. The sign or symptom we should be on the lookout for here is again going to be vaginal bleeding, which is going to be a sign, but our symptom is going to be constant abdominal pain. So our placenta previa was painless bleeding. Our abruption is going to be some constant abdominal pain, possibly even lower back pain, to go hand in hand with that same bleeding. Our care for this patient hasn't changed one bit. We're going to see signs and symptoms of hemorrhage. We're likely to see signs and symptoms of shock. So we're going to treat aggressively for those signs and symptoms of shock, because everything that we do to mom gets transferred to the baby. So get some oxygen running, keep them warm so that we can start to limit some of the problems that mom's going to have downstream from this hypoperfusion, and get this patient laid down, kept warm, oxygenated, and transported. And that's going to be our best bet at having really anything good happen. Ruptured uterus is exactly what it sounds like. A ruptured uterus means that from either a trauma or just a weak spot developing in the patient's uterus that allows it to rupture, that the hollow muscular organ that this baby was supposed to be growing in has broken open, and the baby is actually going to wind up inside of mom's abdominal pelvic cavity, and it is something to behold from what I'm told. I've seen, like I said, I look through a lot of stuff to try and find like interesting articles and pictures and stuff, and I've not found one for anything like this, but this is where we may have absolutely no bleeding. We may have had complete cessation of any uterine contractions. Maybe we can actually palpate the baby in mom's abdominal cavity rather than being able to find the uterus and palpate the baby. This is going to be one of those times like, where's Waldo? This is one of these things is where it's not supposed to be. And that is an absolute fact. This is going to be a situation for immediate transport, because this baby needs to be gotten out of there quick, fast, and in a hurry. There could be minor bleeding. There could be heavy bleeding. Some of our other signs and symptoms are going to be really a little less like, okay, fine, we'll have some abdominal pain. There may be some nausea. Mom may have complained of some like shearing sensation of pain, so like cutting or stabbing. going to have a lot of the same assessment findings, like abdominal trauma. You know, think of the things that could cause something like this. Abdominal trauma being one. We have a weak spot developing in that uterine wall from that trauma, and sooner rather than later, the pressure gets too much and the uterus ruptures. A very large baby, lots of children, difficult labors, history of a prior C-section or uterine surgery. When they do things like a cesarean section or a surgery to the uterus, they compromise the structural integrity, which means the next time this patient has a baby, the pressure on the uterus could get too big and we could have some rupture. Treatment, it's going to be the same as the other two. We're going to oxygenate, we're going to care for shock, we're going to be on the lookout for our patient's condition to deteriorate, and we transport. Ectopic pregnancy, we talked about a little bit yesterday as well. Ectopic pregnancy is when the ovum, the fertilized egg, does not implant where it's supposed to. There are multiple ways that this can happen. It can be in the fallopian tube, it could be in the abdomen, it could be on the cervix, it could be on the outside of the uterine wall, and the baby is not going to be able to grow. If you look at the way the uterus is formed, the placenta and the baby are supposed to begin growing somewhere where there's a lot of room for expansion. If we look at our fallopian tube, that ovum with a barely recognizable even zygote in there is barely got enough room already. And this is not very far into this patient's pregnancy. So this is a pregnancy that is going to be non-viable. This is a pregnancy that actually can kill the mother. Previous history of ectopic pregnancy, a patient who's got pelvic inflammatory disease, patients who have had other problems with their fallopian tubes are going to be very susceptible to this. It begins as a dull, aching type of pain that's difficult to localize, so start to think inflammation and irritation on the patient's lower quadrant. And then when that fallopian tube ruptures and causes what we're going to talk about next, we have a very, very sudden onset of a knife-like abdominal pain that is very spot specific to one side of the patient's lower abdominal quadrant. Patient may have some referred pain to their shoulder. What do you think some of the signs and symptoms we ought to be on the lookout for are?
Something with the heart, cardiac issues.
Cardiac issues. What do you think the body's going to start doing?
Pump more blood.
Yeah, it's going to start compensating. So it's going to start trying to pump more blood. And we will see a patient who is likely hemorrhaging, who is likely in shock, and someone who we may or may not ever see a drop of blood, because all that blood could be on the inside. We may actually see some bruising or discoloration starting to form around the patient's belly button. They may complain of a strong urge to move their bowels. These are all things that if you start to hear enough of these things sort of stacking up with themselves, we used to always say, I can remember this clear as a bell from when I took my EMT class, any woman of childbearing age with lower quadrant abdominal pain is having an ectopic pregnancy until proven otherwise. Now, I'm not going to sit here and harp on you guys about that, but what I do always want you to keep in mind is start thinking worst case scenario type things. And this is something where the amount of bleeding that's been going on, especially if they do then say those, yeah, it was really a dull ache, and then all of a sudden it felt like I got stabbed right on my left lower side. And then you start to see signs and symptoms of shock, and you ask the patient, you know, when was the last time you had your period, or are you sexually active? And light starts to dawn on marble heads. They go, you know, I haven't had a period in 2 months. Like, okay, is it possible you could be pregnant? Well, I didn't think so. And we start to see changes to their vital signs and changes to their orthostatic vital signs. Come to think of it, earlier in the day when I went to stand up, I got very, very dizzy. And those things all in my mind start to tick. And I start thinking, all right, this is a patient who maybe presents as not particularly overly sick, but might they be?
Yeah.
Yeah, this is someone who oftentimes will hide a lot of that, a lot of the, hey, I'm really, really sick, just waving at you, because generally it's a healthy type person. Generally it is someone who, you know, you would think on any other normal day would have no complaint in the world. And now you're starting to think, wow, life-threatening internal hemorrhage and not a drop of blood to be found anywhere. So here's where we're going to talk eclampsia and preeclampsia, our seizures during pregnancy. If mom has a seizure disorder and has a seizure while pregnant, it is life-threatening for both. Mom and baby are now having a life-threatening emergency, because if mom's not breathing, baby's not getting oxygen. We're going to treat these the same way as any other seizure patient. We want to protect them from injury. We want to oxygenate when we can. We want to maintain an open and clear and secure airway. We transport mom on her left side. Does anybody remember the reason why we're going to transport mom on her left side, not supine?
It's the recovery position to keep weight off of the body so it can have blood flow.
Yep.
And breathe.
We're trying to keep that baby off of mom's vascular structures. We're trying to keep the baby from compressing the vena cava and limiting blood flow returning to the heart. You got it, Alex. And then that little pesky little bottom bullet point may be associated with eclampsia or preeclampsia. Now, you're going to pay attention to any words that are going to leave me today. Now's the time. Eclampsia and preeclampsia. Preeclampsia occurs generally, they say, in the last trimester. It's generally women in their 20s who are pregnant for the first time. If they have a history of diabetes, heart disease, kidney problems, or high blood pressure, they are at the greatest risk for this. And one of the things that you'll see is hypertension and swelling during their pregnancy. Hypertension, like blood pressure of consistently 140/90 or better. This is generally someone who, yes, has some concerning health issues like high blood pressure already, diabetes, kidney problems. Those are some of the things to keep in mind. When preeclampsia turns into eclampsia, it's because mom had a seizure. So it is called preeclampsia right up until the point where the mother has a seizure. When mom has a seizure, it turns from preeclampsia into eclampsia. But think things like mom has a complicating medical history. She's been hypertensive and she's swollen and puffy everywhere. Fingers are getting too swollen for rings and things to be on. That is really like the hallmark indication would be our hypertension and our lots and lots of swelling. As a general rule, the medical community has absolutely no for sure reasoning behind why preeclampsia and eclampsia happen. They don't really know. But our assessment findings are going to be a history of high blood pressure, history of diabetes, kidney problems, heart disease, no previous pregnancies. Then we're going to have some neurologic findings. So our patient may be complaining of like floaters or blurred vision. They're going to have consistent elevated blood pressure. They're going to have headache, nausea, vomiting from all of these neurological things. It is imperative to get this patient transported as soon as possible. Because if we think back to the initial slide when we started talking about things that are going to be detrimental to mom and detrimental to baby, seizure during pregnancy is in fact a life-threatening emergency. We covered this already just a second ago. Alex nailed the question, so I won't beat us up with it too much, but look at the picture and you can see just what we're trying to avoid. If we lay mom flat like that, baby's head compresses the inferior vena cava against her tailbone, against her sacrum and the coccyx. And we're going to have a very, very marked decrease in preload, blood flow returning to the heart. Our patient is likely to be tachycardic, hypotensive, lightheaded and dizzy. If we just were to prop them up on their side, and it really is something as simple as putting a pillow underneath mom's right side so she can't lay flat. It really is that easy. We make all of those things go away. So just don't lay your pregnant patient, especially a patient who is visibly pregnant, flat on their back, because you're going to cause a dip in their blood pressure, a spike in their heart rate, and signs and symptoms of shock because the baby is now the obstruction. So
Does it matter if they're right?
we put everybody on their left side just because it helps with our ability to monitor them.
Gotcha.
But in theory, no. Like if this was your significant other and they wanted to lay on their right side instead of their left because it was more comfortable, no, it's not going to make any difference.
All right, thank you.
Yep. All right. I say let's take another 10-minute break or so, and we'll get into happier moments, normal labor and delivery. And on the bright side, most deliveries do just progress normally. Women have been having babies for millennia without the invention or bothering of modern medicine. So most of the time, this goes along swimmingly. So we'll talk about the normal stuff first, and then we'll get into a bit more of the troubling abnormal type things we may see. So let's take a break and we'll come back and talk about birthing babies.
a double PJ. And I kind of like took her and so like I asked her, I was like, yeah, how do you get all that spit to do stuff with? Like, and she was like, oh girl, okay, so what you do is you put your hand all the way down your throat and you just grab yourself until all the throat spit comes out. And that's how you get all that like drool. So like you do this stuff. You just gotta like, make yourself borderline puke. So number one thing I learned is a lot of times when you see the sloppy stuff in porn, it's like that getting explored, but porn. And I think learn porn is three, we'll talk about the third one. Actually, two things you need on any porn set and on
My buddy Lorenzo and Nick were proposing to a lot of them. One actually said,
All right, fellas, here we go. Off and running. We are going to talk about Baby Come Now. So in our trucks, we have a disposable obstetrics kit. It's going to have anything and everything you could possibly need in order to deliver a baby in the field. It has containers for us to carry the placenta back in, because believe it or not, everything needs to come with you. So anything that's expelled gets brought to the emergency room. It's how they make sure that mom hasn't retained any products of conception. It's how they make sure that everything sort of progressed and worked along the way that it should have. It comes with a sheet. We're gonna try and create as sterile of a field as we can. So we have sterile sheeting, we have all sorts of ability to make ourselves a clean space for this baby to come out, because mom's insides are going to be exposed to the outside at this point. So we put one sterile sheet underneath mom right at the vaginal opening. We place another sheet over her legs in the lower portion of her abdomen. We're trying to create not only as clean of a field as we can, but also maintain a little modesty at this point. We want to keep all the rest of our supplies like umbilical clamps and bulb syringes and anything else close, but away from where all the messy stuff is about to happen. The first stage of labor is dilation. Dilation is when regular contractions have begun and the cervix begins to thin and open out. Full cervical dilation is, they say, 10 centimeters. We're looking for contractions. We're not going to be checking internally for mom's cervical dilation. Generally, the first stage of labor can last 8 to 10 hours for a first-time mother. There's no real hard and fast rule as to how long this is going to take, but generally, the first stage of labor can last anywhere from 8 to 10 hours for a first-time mom to 5 to 7 hours for subsequent babies, or it can be even faster than that. Dilation is said to have ended when the contractions are regular in 3 to 4 minute intervals and they last at least 60 seconds each. So we have a pretty decent amount of space between contractions, 3 or 4 minutes, but they last for almost a minute and they're really intense. Excuse me, geez. Braxton Hicks contractions are what they call false labor. Generally, they're very short in duration. They're very irregular, so they're not that 3 to 4 minute marched out, very, you could set your watch by them type of contractions. This is not an indication that delivery is imminent, but it does need to be evaluated by the obstetrical staff at the emergency room. Just because they're not marched out every 3 to 4 minutes doesn't mean that this should just be ignored by mom. This is one of those things that we need to make sure gets its due diligence and we get this patient transported to the emergency room. Our second stage of labor is when mom gets the urge to push. Our patient who is having a baby and most likely going to have a baby right there in the living room or in your ambulance will a lot of times complain of the feeling of needing to go to the bathroom. They feel like they need to defecate. That means delivery is imminent. You may actually see a bulging in mom's perineum. That's the baby's head beginning to push its way through the birth canal and start to spread things out. If we see a bulging of the perineum or the vaginal opening during contractions, this is a sign that the baby has now entered into the birth canal, and that same peristalsis that moves food through our GI tract, that smooth muscle contraction is now working baby towards the outside. Second stage of labor is the beginning of it is complete and total cervical dilation. Pretty simple. The end stage of expulsion, our second stage of labor, is when the baby is out. So once baby is born, our second stage of labor has ended. Generally, our contractions during our second stage of labor are closer together, so 2 to 3 minutes, and they are longer. So 60 to 90 seconds or longer. They're really intense. This is mom really now starting to work at pushing that baby out. So in our first stage, the contractions are further apart and shorter. In our second stage, they're closer together and longer. As the baby starts to push its way downward, think of the bulging in the perineum, bulging in the vaginal opening, the urge to defecate. These are all signs that this baby is coming right this very minute. Another sign of imminent delivery is crowning. If when you do your inspection, you look down and you see a head poking out at you, guess what? We're having this baby right here. There's no time to transport. We're get ready because we're having a baby. Generally, the second stage of labor can be 50 to 60 minutes. If a patient has had more children than just either 0 or 1, so more deliveries, means it's going to be even faster. This second expulsion stage can last for 20 to 30 minutes. My wife, our youngest, was born in 15. So it can happen quick, fast, and in a hurry. This is crowning. You see the baby's head starting to protrude from the vaginal opening. What you see right here is the doctor or whoever is delivering this child with a little bit of pressure on the perineum. This is to help avoid any tearing or ripping from the mom's vaginal opening through the perineum. When we see the baby starting to come out, a little bit of gentle back pressure on the baby's head is going to be very important, especially if this is not the first child. What we're trying to avoid here is what they call a precipitous delivery. That means baby came out like he was launched from a rocket tube. So a little bit of gentle back pressure on the baby's head. We don't want to put any pressure on the face or on those fontanelles on the soft spots. And once that head is delivered, we will start to be able to see if the umbilical cord is around the baby's neck. That's called a nuchal cord. If you have loops of umbilical cord around the baby's neck, this is not cause for panic. You use your finger like a hook and loop it underneath that loop of nuchal cord and try to gently slide it up over the baby's head. Don't pull, don't use a whole lot of pressure. If you can't reduce that nuchal cord, all you have to do is clamp and cut. You find a spot where you can get 2 umbilical cord clamps on that umbilical cord, clamp it off, and cut between those 2 clamps. Then the baby is no longer being strangled. The cord, is no longer being strangled because the baby's not breathing regularly yet. It's still receiving all of its oxygen and all of its blood flow from that umbilical cord. So we can't have compression on the cord. That's something we're going to talk about a lot in the next few slides, is limiting the amount of compression that's on that cord, because that is that baby's lifeline. So it's important to reduce a nuchal cord. And if it can't be reduced, it's important not to do anything to damage it, but clamp it and cut it. Once the head is out, the next big portion of the baby to come out will be the shoulders. As the body's coming out, we want to support the baby. We're not going to pull. We're not playing tug of war. The shoulders will generally be delivered one at a time. We'll pull downward a little bit to help the top shoulder come out, and generally the baby comes out pretty quickly thereafter. The full body's expelled. We're going to hold onto it with both hands. As you can see here in the picture, baby comes out with a whole lot of, oh my God, and they're going to be slippery. So make sure you're on the floor. Make sure you're not really like very high up. Dropping the baby is just bad form. And if you drop the baby, fake a seizure. After the baby is out, we want to keep the baby level with mom's body. There's still some very important nutrients. There's still some very important fetal circulation that's coming from mom and extra blood from that placenta that is going to be important for the baby's development. Once the cord has stopped pulsing, so we're going to keep our hand on it, find one of those 2 arteries, and once the cord has stopped pulsing, we're going to put an umbilical cord clamp about 4 inches from the baby and about 6 inches from mom. We're going to put a clamp in each of those locations and cut between the two of them. We want to make sure we leave enough room because, believe it or not, they can actually start an IV in an umbilical cord if they needed to when we get to the hospital. And it is pretty quick and easy vascular access to the baby. So about 4 inches from the baby, about 6 inches from mom, clamp and cut the cord. And we want to dry and stimulate this baby. I once had an OB nurse tell me that if we brought in a warm crying baby that had been delivered in the field, they would buy us lunch. Drying and warming this baby, scruffing them up with a rough towel is generally all the stimulation they need to breathe and get them to do the things that a baby needs to do. This is another good spot for the use of our plastic wrap in the ambulance. We can warm the baby up, wrap them in the plastic wrap, wrap them in a blanket, and put them right on mom's chest when we're finished there. And most babies do just fine. Most neonates, most newborn babies don't require a whole lot of input from us. They just start doing the things that people do almost immediately after they come out. Now let's have a look at this picture here and tell me what you see on the baby's feet and maybe on this hand right here.
Cyanosis.
You see some cyanosis. How come? Is that normal? Is that concerning?
It's normal because when they first come out, they're not breathing, so you got to stimulate them to get them breathing, and then they start getting the oxygen flowing through them.
Yeah, when we talk about evaluating the newborn, it is very, very common to see some of that peripheral cyanosis. We'll see a little bit of like blue color in the distal portions of their extremities, their hands, their feet, and that is not a huge concern. They're still new to this whole breathing in the outside air thing, and it might take them a minute or two to get pinked up to the point of being pink, warm, and dry. Our stimulation efforts, our ability to warm them and keep them dry and get them going, give them a little kickstart, is going to be what makes that bluing go away. It is going to be what really sets this delivery up to have gone well in the field. Next, we have our third stage of labor right here. This is delivery of the placenta. This can take about another 20 minutes. This is what was attached to mom. It's now on its way out. We're going to deliver this in much the same fashion that we did the baby. We're not going to tug on the placenta either. It is important that we bring this to the emergency room with us. It is important that this gets brought along because this is something that the doctors will be able to evaluate to make sure that they don't need to go in and do any intervention to mom to get that out. Because if it's no longer really connected and there's no more reason for it to be in there, mom can really wind up sick with some pretty serious, pretty systemic type infection if any bits and pieces of that get left behind. If for whatever reason we need to oxygenate a newly born baby, we are going to use blow-by oxygen at first. When we talk about our resuscitation efforts for a newly born infant, we always want to start least invasive. So that tactile stimulation, right, that drying them with a rough towel and flicking the bottoms of their feet, that is normally enough. That's where we begin our resuscitation attempts. And then we get a little bit more aggressive and a little bit more invasive as things move along, because maybe they need more than just that. And we'll talk about the APGAR scores in just a few minutes. But let's get into...
Tommy,
Yo.
quick question. Maybe I missed something, but why or how is it that flicking their feet, like that stimulus, what does that do to the baby to get them breathing on their own?
So it's not always about getting them breathing on their, it's not necessarily going to get them, so quote, breathing on their own. It's more along the lines of aggravating them, to be perfectly honest with you. We're trying to irritate them into doing the things that we want them to do. It's going to stimulate a cry. It's going to stimulate some movement. It's going to get things sort of pumping and flowing and moving around. So it's more just another level of stimulation. Rubbing them up with that towel and getting them dry and adding that next, because again, this is all new. So getting that sort of next level, next little bit of sort of priming them is just what we're looking for. It's not necessarily going to make them do anything that they weren't going to do already. We're kind of just trying to get them started down the right path, because they don't do any actual breathing until they come out, until their chest is delivered. They don't have a normal circulatory system until a little bit after birth, because they're still reliant on fetal circulation until their body makes the change. So the more crying and the more active and the more sort of irritated and aggravated we can make them, the quicker all these things are going to happen.
Thank you.
Yep. So how do we make the decision whether to transport or deliver on scene? Some things that tell you going forward from this moment on that you're going to have a baby right there in this patient's house is there crowning? Are there contractions 2 minutes together or closer? And are they lasting almost the entire time? So it'll seem like almost constant contraction. 2 minutes or less apart and a contraction that lasts for 90 seconds, that means mom's getting next to no break. That means this baby is coming, and this baby is coming right this minute. If the patient feels the urge to move their bowels, that is a pretty good indication, and also be prepared for the fact that they will when they push this baby out. Strong urge to push, no matter what we do. I heard people talking just a week or so ago about, yeah, you take a dime and you put it between mom's knees and tell her not to drop it. None of that's going to work. You could duct tape this lady's legs together, and if that baby is coming, that baby is going to come, imminent. If the abdomen, when you palpate, is like knocking on a door, that means everything is now contracted and everything is in position, and that baby is going to come. You don't want to deliver this baby in the back of your ambulance if you don't have to. If you do have to, you do not want to deliver this baby in the back of a moving ambulance. So when you see signs that birth is imminent, have your partner stop the truck. Because like I said, if your babies are slippery, if you drop the baby, fake a seizure, because you really look, it's bad form and it's dangerous. So do the things you can do to limit and mitigate the fact that this is problematic, because it is problematic. This is an involved thing that we're going to be up to, and there's a lot at stake. Mom, baby. So normal delivery goes a little something like this. We position the patient and create our sterile field. We're going to monitor for vomiting. It's likely. This is intensely painful for mom. We are going to assess for crowning. So we're going to take a look and see, do we see signs of bulging of the perineum, bulging of the vaginal opening, or do we see a head of hair poking out right back at us? If we do, we apply some gentle pressure on the head as it's crowning. If the amniotic sac hasn't ruptured, we want to go ahead and tear that, tear the membranes and get the amniotic fluid out. We want to evaluate for a nuchal cord as the head is being delivered. If we find a nuchal cord, we loop over and pull that cord free. If we can't pull the cord free, we clamp and cut it. This right here is no longer indicated. For a long time, we suctioned every single baby that was born. And come to find out, by too aggressively suctioning a baby, we would cause bradycardia. Now, newly born infants are heart rate dependent on moving enough oxygen around. They cannot have a bradycardic event, even one. So we no longer routinely suction babies just because they were born. For the most part, they clear their own airways, no problem whatsoever, and we don't need to assist them. Even if there's meconium present. If you're going to suction a newly born baby, in your other hand, there needs to be a BVM. Because the only reason we need to suction a newborn's airway is if we're going to supply positive pressure ventilations. So suction is no longer routine. It is no longer really altogether that indicated. We're going to support the baby as it's being delivered. Yes, we can wipe all the schmutz out of their mouth and nose. We want to dry them, wrap them warm, and keep them that way. That is going to be the best possible thing we can do for this little critter. We're going to assign our partner to be in charge of the baby, because how many patients do we have now?
Two.
Two. And really, your hands are going to be full. You're only going to be able to appropriately care for one. So somebody takes care of mom, somebody takes care of the baby. We clamp that umbilical cord, like I said, somewhere 4 to 6 inches away from baby, somewhere 4 to 6 inches away from mom, and cut in the middle. We observe and transport after the delivery of the placenta. Now, if the placenta has not delivered within 20 minutes, it's just time to leave. The placenta is still there. It's not going anywhere. So if it's been 20 minutes and the placenta isn't out yet, it's time to go. We're going to place some of those sanitary pads out of our OB kit into the area of the vaginal opening. We're not putting anything inside. We just want to try and contain as much of the blood and anything else that's going to be coming out. We record the time of delivery, and we transport everybody and keep them warm. Now, what I'm going to tell you is, here in the Commonwealth, it is 100% against protocol to transport this baby on mom's chest, skin to skin contact, hopefully nursing, and keeping everybody nicely warm and packaged. Why do you think that is, other than the fact that Massachusetts just likes to be a pig?
A possible car accident could occur, hitting a bump, baby falls off mom, baby hits the floor, baby has a seizure.
Yeah, all sorts of bad things can happen. Now, I don't know any way, shape, or form that you're going to talk this new mom into handing the baby over and putting them in another ambulance to bring them to the emergency room. There is no workaround. There is no fix. This is just not ideal. But there's my spiel. It is, quote, against the rules to transport this baby where everyone in the world knows this baby needs to be. So good luck and Godspeed when it comes to that. Since we're being recorded, that's where we'll stop. Moving on. If we notice a significant amount of postpartum meaning the mom is no longer pregnant, we now have baby, postpartum hemorrhage, we're going to massage the uterus. The massaging of the uterus will actually stimulate more muscle contraction and start to limit that bleeding. One of the other things we can do is try to encourage mom to have the baby nurse, because that will also release some hormones that will limit the amount of postpartum hemorrhage that's going on. Now, some blood loss is expected. What we're talking about here is a significant amount of blood loss, enough leaking that makes you concerned that mom's not doing so well and could be hemorrhaging. So signs of symptoms of shock, those kinds of things. This uterus massage is, you're actually going to find mom's uterus. It's located just above her symphysis pubis, so her pubic bone. And you're actually going to really sort of work at massaging and kneading that uterus so that you can get this bleeding to sort of stop itself. As far as care for mom goes, we're going to monitor for signs and symptoms of shock. We're going to transport. We're going to continue to massage that uterus en route. Now we're going to get into some of our abnormal presentations and difficult deliveries. So we're going to assess the exact same way as a normal delivery. Set everything up the exact same way as a normal delivery. And some things that we're going to see are a presentation of something other than normal crowning. So when we do our inspection and we look underneath and we expect to see crowning or a head sort of bulging at the patient's perineum, instead we look down and we see a prolapsed umbilical cord, an arm, a foot, something that is not a head looking back through the birth canal at us. Gonna present some problems as far as delivering this baby in the field. We could have some abnormal color or smell to the amniotic fluid. We have some particular problems with pregnancies before 38 weeks or after 40 weeks, because the longer the baby is in there, and they don't typically let this happen that often anymore, but the longer the baby is in there, the more it's going to grow and develop, the more unstable the placenta is becoming, and that baby is going to be humongous when it comes out at 42 weeks.
I noticed that. That's why they started inducing a lot of women lately at the hospitals as part of their protocol.
It's a hairy situation. It's dicey at best if mom is greater than that 40 weeks, because there's a whole host of issues that can go along with that. And then we have the recurrence of contractions after a first infant is born. So we're talking multiples at this point. So let's get into some of our presentation issues. First one being a prolapsed umbilical cord. Remember, that umbilical cord is that baby's lifeline. That umbilical cord cannot have any sort of pinching, any sort of compression to it, and have that baby still well perfused. We want to make sure we tell mom in no uncertain terms, do not push. We don't want mom trying to push, because that's just going to increase the amount of constriction on that cord. Talk them through their contractions. They have to fight that normal urge to push. If you look at what's going on in this picture, that is legitimate. You're going to reach inside this patient and use your fingers to lift the baby's head up off of the cord, lift mom's anatomy up off the cord. Whatever you have to do to get the pressure off of this umbilical cord, that's what we're going to do. When we get to talk about transporting mom, we want to transport mom in the knee chest position. So we want her face down with her knees brought tightly up to her chest and the baby making pieces up in the air. We're trying to now work with gravity in order to help this umbilical cord. Treatment for the cord is to wrap it in a sterile, moist towel and get to boogieing, because this is a legitimate emergency. You can't deliver this in the field. You shouldn't even attempt to deliver this in the field. Transport, keep mom warm, keep the pressure off the cord, and oxygenate. Next, we'll talk about breech delivery. Breech delivery, it is not ideal to be delivered in the field, but can be. Really, if any of the feet or buttocks are presenting themselves first, we want to get on about the business of transporting. breech birth is either the buttocks or the lower extremities first. It can be delivered in the field. Like I said, it is not ideal. As the chest is coming out, the baby is going to be stimulated to do what?
To breathe.
To breathe. There's no longer that compression on the baby's chest. So this is how we're going to manage that patient's airway. It's another time where we're actually going to, almost like back when we learned CPR and we were talking about a choking infant, right? You have those fingers creating a space for the patient's airway. We're going to do the exact same thing. Like I said, if the baby's going to come right now, the baby's going to come right now, and there's not a blessed thing in the world you can do to stop it. But we should probably be working towards transporting this patient rather than trying to deliver this in the field. When we see signs that this birth is imminent, whether we like it or not, we're going to have to stop and get ready to deliver this baby. But keep in mind that baby's going to be stimulated to breathe the minute that the chest and shoulders come out. So we want to take care to make sure we provide a space for that baby to breathe. Limb presentation is another problem. So a limb presentation means this baby's not really in sort of the delivery fashion, because only one now, instead of either both feet being present or the head being present, only one piece of this baby is actually out. Do not attempt to deliver this in the field. This is not going to happen. If we see limb presentation, this is going to be a emergent cesarean section when you get it to the emergency room. We want mom in that same knee chest position with her face down on the stretcher, so gravity is helping us out. Don't touch the protruding limb. Don't try to push the protruding limb back in. Just transport this patient and oxygenate mom. Oxygenating mom will keep baby well perfused. Keeping baby well perfused is going to keep baby alive, even with this protruding limb. Multiple births, well, you did one. There's no problem doing two. The big thing you need to think of with multiple births is legitimate birth-like contractions begin to start back up after the first baby is born. We should already have another ambulance on the way to care for our second patient. We need to make sure that we have a way to keep straight which baby was baby number one and which baby was baby number two. Writing on them with a Sharpie is not the answer. Putting an extra umbilical cord, putting an extra something on the first baby that came out or the second baby that comes out is going to be the way to take care of that. A lot of second babies in a multiple birth scenario are breech. So we need to be prepared for that baby to be in breech presentation. We need to be prepared for babies that require a little bit more as far as care and treatment goes, because they're likely to be of a lower birth weight. So be on the lookout for babies that maybe need a little more than just that warming, just that tactile stimulation in order to come around. Meconium is when we have a foul smell or color to the amniotic fluid. Generally means that the baby was under some sort of stress in utero and actually defecated in the amniotic sac. Meconium will be sort of a blackish brown stain. You can see it right there on that on the baby's face. Still, unless you're going to ventilate that baby, there is no reason to suction it. We can just clear the airway out with some manual maneuvers. We can get that airway pretty well taken care of, and the baby should start doing all of its own baby things, hopefully pretty soon thereafter. Premature birth, most of the time these can progress just as any other pregnancy, any other delivery. It just means that the baby is being born before 38 weeks of development. So babies are considered full term at 38 weeks because it's entirely possible they missed the due date by a couple of weeks here and there. Premature infants are generally thinner, they're generally smaller, they're kind of wrinkly because they haven't quite grown into their skin yet. We're still going to work aggressively to avoid heat loss. I've probably said it 100 times already, but keeping these babies warm is absolutely the most important part of most of what you're going to do, because most babies just start doing it on their own. There's not a whole lot of input. Post-term pregnancies, so that's after 42 weeks, because like I said, they can miss it by about 2 weeks here or there. The placenta begins to degrade and decline. The baby's not getting as much oxygenation. The baby's not getting the nutrients it needs. Blood flow is really starting to suffer. The post-mature baby is very prone to having problems from insufficient oxygenation. So we could have some hypoxia. The baby's skull actually starts to harden some in utero, so it doesn't compress and fit through the birth canal and the cervix quite as nicely as a regular term baby. Generally speaking, with prenatal care being what it is right now, a lot of the problems that we talk about as far as delivering babies and all that goes have sort of been evaluated right out of our wheelhouse. Because when an obstetrician sees a placenta previa, sees a baby who's not in proper alignment to be delivered appropriately, sees a baby who's at 42, 43 weeks, what do you think they do? You think they just they roll the dice and let it be?
Prepare for a C-section?
Yeah, they prepare for this patient to not be able to deliver this baby vaginally and naturally, and schedule a time somewhere around 38 weeks, somewhere between generally 36 and 38 weeks, where they're going to go in and take this baby out. So that way we don't run into all of the complications and all of the problems of trying to deliver this dangerous pregnancy regular. So they go in and they will actually either induce labor or go in and schedule a C-section. And as much as a C-section is way, way, way more intensive for mom, it makes it a whole bunch easier for the baby, and long-term makes it easier for mom. We don't see a lot of this trouble anymore with imaging being what it is and medical care being what it is. We've kind of gotten away from sort of, well, we'll just see what happens. Shoulder dystocia is something you may see, especially for first-time moms or women of a very petite stature. This is when one of the baby's shoulders actually becomes trapped behind mom's pubic bone. What we'll see is what they call a turtle sign. Turtle sign means when mom gets the urge to push, baby's head starts to present like it's going to come out. And then when mom's relaxing and not pushing anymore, baby's head sucks back in like a turtle. We're not going to pull on the baby's head. We're not going to attempt to deliver. We want to transport immediately. We also, one of the interesting things we're going to instruct mom to do in this is pant, like breathe heavy. We're going to have her on her back with her knees pulled all the way up to her chest. That's called the McRoberts position. This is an effort to try and stretch out that pelvis, stretch out that birth canal a little bit, and get that baby's head and shoulders through the birth canal so we can get the baby out. We have all sorts of problems that can happen with this shoulder dystocia. We can have entrapment of the cord. If part of the baby is out, but not all of the baby is out, we start to have problems with a child now who's still doing time on the inside, but trying to breathe externally, and it's not really working out for them, because this can lead to severe brain damage and death before too long. So now let's talk care of our newborn. In case me saying it didn't really drive home this point quite well enough, we no longer look for that routine suctioning. If you are getting ready to suction a patient that is a baby, a newly born baby, and you are not getting ready to ventilate this patient, you're wrong. If you are going to ventilate and there's still meconium or fluid or anything in the airway, by all means provide some suction, because at this point, that's the least of the baby's worries. But if you're not getting ready to ventilate, you shouldn't be getting ready to suction either. Keep them warm. Our APGAR scores. APGAR stands for appearance, pulse, grimace, activity, and respirations. So appearance, is the entire body cyanotic or pale? Or are the hands and feet just a little pale? Or did, for some unknown reason, this baby came out completely pink and looks great? If we have cyanosis of everywhere or pale skin on this baby, this is by points. So the worse the patient is looking, the worse the patient is doing, the lower they're going to score on our APGAR. So blue or pale, 0 points. Pink body, blue extremities, 1 point. Pink all over, 2 points. It's pretty straightforward. Activity, their muscle tone. Are they not really moving? Are they flexing and extending their arms and legs? Or are they doing the whole baby wiggly worm thing? Now, this is something that you will see on the National Registry for sure. A pulse below 100 or over 100. Over 100 is good. Below 100 is not so good. And what do we do if our baby has a pulse of below 60 and signs of poor perfusion?
BVM.
Begin resuscitation.
Begin resuscitation, including a BVM. Below 60, signs of poor perfusion with a neonate or an infant, we're going to start cardiac arrest management and begin CPR. So when we're evaluating our newborn, we take an APGAR score at 1 minute, and then we take an APGAR score at 5 minutes. And generally speaking, our baby who scored most of our points in the 1 minute check, and then probably scored all of our points in the 5 minute check, requires not much from us as far as treatment goes. It's really just going to be supportive and a ride to the emergency room. Our baby who didn't score so hot and isn't looking so good, they probably require a little bit more care. Most infants just require the basics. Some signs and some things that are telling us that this patient is pretty severely depressed is going to be a respiratory rate of above 60, a heart rate that is either above 180 or below 100, and signs of trauma, signs of poor muscle tone, so a baby that's not really moving around a whole lot, or an APGAR score of below 4. So if we get back to our APGAR scores, you don't really have to be doing a lot as a brand new baby to get an APGAR score of 5, right? We really don't. Let's say we have flexed arms, a pulse that's maybe just below 100, minimal responsiveness, but a pink body, and slow and irregular respirations at 1 minute. You still got 5 points. So this is not the time to panic. All one of these things needs to be is okay. So we have 1 here for the flexed arms. We have 2 here that gives us 3 points. We have another one here that already gives us 4. Then we have 5, 6 points. And you can already see, like, all right, I understand this flow chart here always made sense to me, even as much as there was no part of me that wanted to have to deliver a baby in the field. Most infants come out requiring very, very, very little input from us. But if they do, here's the way we work it. You look first, our inverted triangle for neonate resuscitation is dry, warm position, suction, some tactile stimulus. So we are really just trying to aggravate this baby into doing what we want it to do. We get that towel and we scruff them all up. We keep them nice and warm. We position them on mom's chest, some skin to skin contact. We flick the bottom of those feet. And most of the time, that is enough to get them crying. If they're crying, their heart rate goes up. If they're crying, their respiratory rate goes up. Their movement increases and they start to do that whole baby wiggling around thing. And you'll watch your APGAR score in 5 minutes shoot right to the moon, because no baby comes out with an APGAR score of 10. That's not a thing. It isn't. If our drying, our warming, our positioning and all that isn't working, we switch to some oxygen. First, we start with blow by, so that oxygen tubing just in front of the baby's face, holding it there, letting them get some additional gas. If that doesn't work, we can switch to a non-rebreather, or we can switch to manual ventilation with a BVM, because BVM ventilations are also that next less aggressive, less invasive step. And then if that doesn't work and our baby is still not doing well and we have a heart rate of below 60 with signs of poor perfusion, we switch to chest compressions. Anybody got any questions?
A lot.
Well, today when you get here, we're actually going to play. We have a mannequin that will birth a baby. So we'll play around with that a little bit. We'll see what other kinds of fun and games we can get into. It's something that happens all the time with and without our input. Delivering babies and women having babies. Hell, sometimes women deliver their own if they don't have a way to the emergency room, and it just sort of happens. So it's frightening. I'll give you that. It is definitely one of those things where it's like, holy crap, I don't want to have to do this, but looks like I'm gonna. But you guys will be all right. We're not really there to do much except make sure the baby doesn't hit the floor. So, all right, that's all I got for you this morning.